Times, COVID-19 Comes to America, presented by Dr. Marc Laforce from the St Anselm class of 1960. The college is committed to keeping our alumni and our friends engaged by offering webinars, podcasts, and fun social media challenges. I, for one, have been incredibly impressed by the variety of programs that have been offered so far, and I encourage you to contact the Alumni Relations Office for suggestions of future programs. We're always on the lookout for new programming. Today's webinar is being recorded and will be posted on the college's website for those who couldn't make it live today. Dr. Laforce will speak for about 20 minutes or so, and then we'll take some questions. There's a Q&A button at the bottom of your screen that I would suggest that you use if you'd like to submit a question, and we'll get to those after Dr. Laforce speaks. I'd like to just introduce Dr. Laforce. He received his BA from St Anselm College and earned his Doctor of Medicine from Seton College of Medicine and Dentistry. He completed his internal medicine and infectious disease training on the Harvard service at Boston City Hospital. He is board certified in internal medicine and infectious diseases and is a fellow of the American College of Physicians and the Infectious Diseases Society of America. He has held research, academic, and administrative appointments at the University of Colorado School of Medicine and the University of Rochester School of Medicine and Dentistry. He currently holds the rank of clinical professor at the NYU Langone School of Medicine in New York City. Over the last decade, he has worked on the development of new meningological and streptological vaccines for resource-poor countries, living the Anselmian spirit. Dr. Laforce currently serves as Director of Technical Services for the Serum Institute of India, and we are very fortunate that he has taken a few moments out of his day to join us today to share his expertise and his insight regarding the current pandemic. Please join me in welcoming Dr. Marc Laforce.
Thank you, Dr. Favaza. It's good to sort of come back in a way, although the news that I'm going to go through is hopefully a bit optimistic, but we got problems. This is my background in infectious disease. I have a long experience in ID and epidemiologic problems in the US, Africa, and Asia, and I'm currently a proof of concept vaccine developer. What I am not, I'm not a businessman, I'm not an economist, and I'm not a politician. The presentation is strictly a personal commentary based on my experience. The COVID-19 story is one that we're actually witnessing as it wends its way through the world, frankly. It started right after the first of the year, at least in epidemic form in Wuhan, and from Wuhan has really spread globally. The organism is called COVID-19, is much like within the SARS family of organisms. This is a respiratory pathogen. Clinical manifestations are of generally respiratory disease, but it has a distinct predilection for old and debilitated individuals, and it develops into a severe acute respiratory distress syndrome with very high fatality rates. In the United States, COVID-19 was probably circulating, we think now, in late December And certainly in January in New York City, it was widely circulating before the epidemic really got rolling sometime in February. Since then, the organism has invaded every state in the union, and cumulative cases, as you know, are over 1 million cases, with now over 70,000 deaths that have occurred. And the 70,000 deaths, I would add, is a conservative estimate, and it's probably more like 80,000 because there are a lot of excess mortality that has been reported that simply hasn't been diagnosed, but most assuredly was caused by COVID-19. We are in the midst of a major epidemic and a major problem. I think one of the most appropriate ways of understanding what's going on is to sort of understand how this organism circulates and spreads. And this, I think, is comprehensible most easily if one deals with the concept of what's called R naught. R naught is really a measure of the infectiousness of this pathogen. And this is a figure that epidemiologists use that basically express the average number of people who will contact the disease from one person who has the disease. Logically, the higher the R naught, the more infectious is the pathogen. For influenza, the R naught is between 2 and 3, but for a disease like measles, it's as high as 11, which is why measles is so infectious and so difficult to manage. In some elegant studies done in the UK in the 1980s by mathematicians and modelers, R naught was defined mathematically. And I think it's worthwhile spending a little time on this simple equation. The R naught is calculated by multiplying a constant called beta that is an expression of the efficiency of transmission of that particular pathogen, multiplied by an expression for the contact rate. In other words, how much contact does an individual who is ill with coronavirus have with others? And that's multiplied obviously by the length of infectiousness of that particular individual. When you multiply all of those out, it works out for COVID-19. It seems to be a little like influenza with R naughts between 2 and 3. Now, what does this actually mean? And in this slide, I think this is an accurate description of precisely what an R naught of 2 does. On the left-hand cartoon, we've got this coughing individual in red who's infected. And with an R naught of 2, it means for each contact that 2 individuals will become infected for each contact point, such that after 4 contact points, that one person has now morphed into 16 infected individuals. And when you express this mathematically, there's an exponential function that I think easily explains how a virus like this really gets going. And the New York Times, it publishes these doubling times for COVID-19. And what they've done is they've put together data for New York City, Boston, Miami, Washington, and Seattle. And the point of this slide is to show that they, at the beginning of the spread of this particular agent, they all follow the same curve. This is the same organism doing its mischief but it just got an earlier start in New York City and more quietly, such that there were more individuals who could really apply this multiplicative effect of infection for this particular pathogen. And what we end up with is a situation that is just graphically shown here in terms of how a susceptible population reacts to an agent like COVID-19. You end up with an enormous number of cases occurring over a relatively short period of time. And when I say short period of time, I mean 3 to 6 months. And that's expressed in red. And what you've heard a great deal about from public health individuals is the importance of flattening the curve. It's really important to understand what all of that means. If the organism is allowed to express itself in its full potential, we rapidly would outstrip any ICU beds that we have for those individuals who develop respiratory and more severe complications from the disease. This is what happened in New York City. And so when epidemiologists speak about trying to spread this particular curve, it's really with the notion of preserving the clinical response that is going to be necessary in terms of saving lives. I'll point out, though, that if you look at the red area, that is without protective measures, and the flattened curve with protective measures, think about what the area is like underneath those two curves. They're the same. So it means that instead of all the disease being over in 6 months, there's no fundamental change. It just is going to percolate along, and it will simply take more time. How do we conceive or think about public health measures that could be effective in terms of flattening this particular curve? And I go back to the R-naught equation, where we have a constant, the contact rate, and the duration of infection all being multiplied. We can't change the duration of infection. That's a constant within the organism's pathophysiology. And in the same way, we can't change the transmissibility constant, which is unique to that particular organism. The only weapon that we really have for this acute phase is the contact rate. And on the left, what you have is a whole series of modeling exercises that show how you can modify the number of cases in terms of the interventions that could be done to minimize the contact rate. And you can go from that black line down to the lowest line, which shows what happens with case isolation, home quarantine, social distancing, all of the mechanisms that were put into effect not only in New York City, but throughout Italy, in certainly South Korea, parts of Germany. They all work. But they are temporary measures, because individuals who might not become infected are still fully susceptible to this particular organism. Which brings me to what could change this epidemiologic picture. Well, I think there are two reasonable options. One, if there was a new antiviral therapeutic agent. And by that, I mean it would be sort of like an agent like penicillin to treat something like strep infections, where we know that the medication is easily available, it's the organisms are uniquely susceptible, that is, the streptococci are uniquely susceptible to penicillin, and that this works. We don't have anything like this for COVID-19. The new information that recently was published about remdesivir as a new agent, this is sort of an adjunct agent that may sort of decrease the length of time that individuals are sick, but it's not like having penicillin for strep infection. More realistically, a vaccine could be developed and introduced. This will take some time, likely a year or two. And I want to spend a moment, sort of showing how a preventive vaccine could be a game changer for this. And it's a game changer because this goes right to the heart of the equation for R naught. If we assume that the R naught is 2 for the sake of this presentation, and a new vaccine specifically was 90% affected, the population protected after vaccination, or obviously the number of infected, that number vaccinated times 0.9. We can also calculate the fraction of the population that need immunization to generate herd protection from that initial equation about R naught. It works out that the calculation is 1 minus 1 over R naught. And if you go through this particular exercise, it indicates that if you get about 55% of a population vaccinated with an effective vaccine, this organism disappears because the R naught falls to less than 1. Once the R naught falls to less than 1, it means there's a decreased number of infections that occur with each infectious cycle, and the organisms simply disappear from a population. This particular cartoon would show what it is that I'm talking about. You can see the coronavirus, which is this big ball, and it generally circulates through a population, and there are groups or individuals who suffer worse disease. Usually these are individuals who are old or incapacitated with lung disease, severe obesity, et cetera, et cetera, et cetera. And these are the individuals that end up going to our ICU units. But with a potent vaccine, the vaccine or the immunoglobulins that are generated with a potent vaccine prevent the circulation of this organism in individuals that have been immunized, so that functionally the organism doesn't have anywhere to go and it literally disappears. To show you how this works a bit, this is what's called the power of herd protection. I have 2 panels here. The top panel shows what happens if you have an organism that has an R naught of 4. That is twice as infectious as COVID-19. You can easily see that in a population completely susceptible, you get to 16 in 2 cycles. But if you end up with 75% of that population now immunized with an effective vaccine, that goes from a transmission rate of 16 with an R naught of 4, everyone susceptible, to essentially a transmission rate of only 1, because the organism doesn't have a place to go as it circulates from one individual to another. A even more telling example, and a personal one, has to do with the circulation of Neisseria meningitidis. This is meningococcal disease in West Africa. And that circulates with an R naught of somewhere around 1.35. And this just simply shows the Neisseria meningitidis circulating in this population. but now facing the challenge of having 95% of the population having received an effective vaccine. That organism simply gets to that immune wall and can't go anywhere, and it disappears. And so this is how a vaccine, an effective vaccine widely used, can have a huge impact on what happens to this particular infection in a population. So what are we left with? We're left with uncertainty. We know that distancing, quarantine works, but there are collateral economic costs that are severe. And how do we manage all of that? And I would offer two observations. One, I think we need to dramatically increase testing so that we can have accurate information on who's infected and who is immune. Only when we have these data can we apply regionally specific strategies like intensive contact tracing that would balance coping with the virus and getting people back to work expeditiously. Secondly, it goes, I think there should be a major emphasis in terms of getting an effective COVID vaccine developed, licensed, and affordable, an affordable vaccine as soon as possible. What is also likely to take place is a epidemiologist that I've worked with from the University of Minnesota, who's just published over the weekend what their modeling exercise would suggest is going to happen in these three scenarios. The scenarios are expressed over a 2-year span of time. I think it's more likely that we're going to follow scenario 3, but I include the slide just simply to say that this is not something that's going to be gone overnight. Lastly, and a more hopefully positive sense, was the New York Times on April 28th emphasizing that the researchers at Oxford at the Jenner Institute, having reported the challenge studies of a new vaccine to primates, that is monkeys, as showing that the vaccine was completely protective. And so I think that's a piece of good news, and hopefully that will be substantiated as new studies unfold. Thank you, and I'm happy to take any questions on any of the material that I've presented.
Thank you so much, Dr. Laforce. That was really informative and so helpful as we think about the progression of the pandemic and the implications for our lives, and no matter what profession we're in or for our families. So looks like we do have a few questions, and so I'll read them. I'll read a question, and then we'll take time to answer, and we'll just go through and see where we end up. So the first question is, can you comment on why or how this disease seems to be presenting in children as a virus leading to cardiac arrest when it was reported as a relatively stable virus early on? I mean, stable, I'm assuming what they mean there is stable for children. Could you comment on that?
Sure. One of the things that happens once a pandemic gets started is that you make some clinical presumptions that change, frankly, over time. And there are now some syndromes that are being described in pediatric units, and the pediatric units, the illnesses resemble what's called Kawasakis disease. This is a highly reactive, and we don't quite understand why that particular disease is expressing itself that way. But I would submit that this is part of a really brutal learning process that we're all going through. I can't explain why this is happening. I do think that this is just the beginning of some clinical observations that are going to require a lot more study.
Thank you. So is there another question that's come in, and you spoke about this in your presentation. Is there a benefit to testing everyone, healthy community, as well as those who might have risk? And is there, and when we talk about testing, are we talking about swab versus antibody testing? So your thoughts about that?
Sure. I think when I refer to testing, I'm referring to both. And I think that there is great value in doing this in quote unquote normal populations, because after all, that's the only way that you establish what epidemiologists call the denominator. In other words, are these populations completely susceptible? I'm afraid that the more we look at the impact of this particular virus, it turns out it's pretty sneaky. And it's probably been out and about a lot more than we think. And so when I refer to the need for this particular testing, we've got to know who's got it and who has had it before we can make sound public health decisions. I would offer one more thing. In today's New York Times, in the COVID section, they describe a major effort in Germany where they're actually doing a randomized sampling that is going to encompass the entire country for their sampling. That's the sort of sampling that I'm talking about.
It's really interesting and kind of overwhelming, but it's certainly something that you keep reading more and more about the necessity of testing the population. Well, related to that, and certainly a question that I did not submit, but I certainly could have submitted, is Dr. Laforce, thank you for taking the time out of your busy schedule to do today's webinar. One question: if you were advising colleges and universities on reopening in the fall, what would your advice be? So obviously something we're thinking a lot about right now. So any thoughts you might, if you were talking to, say, the president of St Anselm College, what would you say to him?
Well, for my French background, I'd say bonne chance. But seriously, I think that educational institutions obviously have an obligation to providing a safe haven for any student coming. And so I think that there is inherent in that particular statement is that the college needs to make sure that it has the highest quality technical advice in terms of either reopening or having testing done on the campus, et cetera. And I'm not sure, to my knowledge, no institution has yet published a particular folder or whatever. And I certainly think that this is a fundamental responsibility of hopefully a series of consortia that involve colleges, because there's a great variety in size of colleges, a mix of different colleges. And if the colleges were to get together and then develop their own particular strategies that may be different for St. Anselm versus the University of Michigan, But I think that this is really frankly, a presidential task in terms of ensuring that that happen.
Thank you. Yeah, it's something we take pretty seriously, but you're right. We're seeking out as much professional advice as we can at this point as we chart that path forward. But thanks for that. One other question, and I'll add to it actually. How soon do you think we will have a vaccine in light of the studies that you mentioned? And then a second part of that is, have you been tracking any of the developments with regard to contact tracing technology? Is there promise there also? So the quickness of the vaccine and then contact tracing.
Okay, fine. In terms of quickness of the vaccine, I headed a project to develop a new vaccine where the basic science was pretty well understood, and that took 9 years. Developing vaccines is just not easy. It's as I've always said. I said it's not a work for cowards. I mean, it really is enormously complicated. Having said that, there are regulatory issues that could be drastically simplified. And I think this is what I was referring to when I said that individuals need to pay attention. And governments need to obviously make it easier in terms of the administrative steps that need to be taken by individual vaccine developers. I'd say the same thing for the World Health Organization. You know, WHO, this is a pandemic, a global pandemic. And I think that we're not completely well served if we concentrate only on ourselves. We have to think about everybody. And if we think about everybody, that means affordability. It's not a question of who's going to make which bucks for what, but it's a question of just simply stopping this particular infection. And that requires major developing country vaccine manufacturers to produce literally hundreds of millions of doses of vaccine or billions of doses of vaccine expertly and, as I said, affordably. So that's the vaccine. Contact tracing. Contact tracing is something we just have not spent enough time developing. One of my experiences was I was a smallpox epidemiologist during the eradication of smallpox in the mid-1970s, largely in India and in Bangladesh. And that disease was controlled through contact tracing. And the contact tracing was incredibly effective in terms of basically identifying who saw whom, who did we have to follow. And once you got your arms around that, it basically imploded because there were no surprises. You knew what was going on. And so to the extent that that this can be developed, I think this is nothing but good news. And this is why I'm very encouraged with what's happening in Massachusetts. Massachusetts, through a consortium that involves academic institutions, but also great leadership from the governor of Massachusetts in terms of establishing and funding a contact tracing approach, which I would predict is going to be somewhat complicated to initially set up, but it is something that will pay off huge dividends over the next 6 months.
Thank you. I'm going to pull together a couple of questions here. One question is about what's the likelihood that this virus will become more like a permanent seasonal illness similar to other coronaviruses, such as the common cold or influenza. And uh, and I guess related to that, then, what are your thoughts about it, if in lieu of an effective vaccine, is there any hope for an effective therapeutic being developed before a vaccine? So in other words, I guess being able to treat the virus
Right.
rather than, if we get it, it's not deadly or less deadly.
All
Right.
right. One of the predictions from the University of Minnesota is exactly that, is that what we're looking at is this is the first step of this particular virus, and it's going to be a virus that's going to be around not for years, but for decades. And it will establish itself like other coronaviruses. And I would think that that's eminently possible. No, that is eminently possible. And so this organism may just simply become a new member of the pantheon of organisms that basically make up organisms that circulate locally and globally. So the answer to that is yes, that's entirely possible. And I would not be surprised if that's exactly what happens with this. So that makes the reason for getting a vaccine that much more impelling, frankly. Second was the vaccine. Oh yes, and the therapeutic. I'm less confident about that because the antiviral therapeutics, well, I shouldn't be perhaps so negative about it, but because the experience that we've had with HIV infection, where basically the therapeutics have been game changers, frankly. And so the answer to the question is, I don't know enough about it, frankly, to answer it correctly. If that were to happen, that could be a game changer.
Another question came in is that if, as you say, this virus is going to be around for years, would it be likely that if we develop a vaccine, kind of like the flu, would this be something that would have to be a seasonal vaccination? Like, so in other words, you get your flu shot every year, and it's a different one depending on the flu strain. Would this be something we'd be looking at?
Yeah, I think that's a great question. And I think that remains to be seen. We're not sure of how quickly well, we don't know enough about the actual pathophysiology of this particular virus. But, could this virus evolve so that minor changes occur such that it just perpetuates itself within a particular population? I think that, yes, that's entirely possible. And there's lots of virology and genetic information to suggest that that certainly might happen.
So one question, and certainly this has been debated by the media, if a person recovers from COVID-19, are they now immune? From your perspective, what do you think?
Yeah, my perspective is I would say yes, because, and I must admit, I think that some of the reporting that's occurred in terms of this has been not terribly helpful, because what individuals have sort of talked about is they're frankly in the weeds too much, as far as I'm concerned. I have a great faith in the immune response being able to control this particular infection. And over a period of time, immunologists will tease out exactly which antigen or which antibody against which antigen, turns out to be the protective antigen. But I feel very confident that these individuals are protected after they develop their episode of COVID-19. The ancillary proof for this are in the passive antibody studies. You know that the individuals who have recovered from the disease, their serum is very, very valuable. We learned that during the Ebola virus catastrophe, where basically immune serum was life-saving for individuals who were suffering from Ebola. I suspect the same thing, and there have been these reports that are really quite striking in terms of individuals who are at death's door, who receive a transfusion that included antibodies from an individual who had developed protective antibody as a result of their particular infection, and that these episodes were really quite striking in terms of improving the prognosis of the individuals treated. I'm sorry, that was a convoluted answer, but
No. It actually was very, very hopeful in some ways. So thank you. I'm going to switch topics a bit. A couple of questions here about your thoughts about some states, Georgia to name one, opening so soon. What do you predict will happen? Is it your opinion that it's too early for reopening to happen? Should we stay in lockdown longer? And are the social distancing guidelines that are put in place, do you think those are sufficient that states are doing as they reopen?
Yeah, I think we know how to do this. And I think the impact that we've had when we've done the social distancing, et cetera, is such that we know this works. I think Georgia's going to get hammered. I think that in the absence of information, and again, this is this whole testing mantra. And this was one of the initial recommendations that I've made, is that if you have testing data that guides your particular political or economic decisions that in terms of what gets open, what's not open, fine. That I think is perfectly sensible. But in the absence of that particular information, and Georgia's got, I believe, somewhere in the range of 30,000 cases that they know about, that means that there's probably 100,000 individuals in the state of Georgia who have COVID-19 disease. That I just think that that's a little bit too fast.
Puts the ability to flatten the curve at risk, it seems to me.
Oh, yeah. No. And then what happens is that if you don't flatten the curve, and you allow the disease to express itself the way it is being expressed in some of these particular areas, it's always the poor. And frankly, if you look at death rates of Blacks who get this particular disease, look at the data from Michigan and Georgia, or I should say Louisiana and Michigan. In Michigan, Blacks make up 15% of the population, but they make up 48% of the fatal cases of COVID-19 for the entire state. Same data for Louisiana. So that I do think that we have an obligation to pay attention to who are the individuals who are most at risk. And you don't have to be a genius to figure that out. It's the poor, the individuals who are crowded together, the individuals who are in service industries, who don't make much money, and who are going to have to go out to work in order to make sure there's food on the table.
Well, so related to that, do you have thoughts about what our political leaders, both in the US and world leaders around the world, could be doing or should be doing to combat the virus?
Oh yeah, and again, I make no bones about that. I've spent much of my career working with the World Health Organization. WHO has got its faults, and no question about that. But in instances like this, it's the only game in town. Frankly, it is the only agency that really knows what's going on in individual countries. And there's always a lot of politics with a lot of this, but I would have hoped that there would have been a general consolidation under WHO leadership in terms of being able to pull what countries are doing and doing this in a more collegial and a more collaborative effort than has taken place. Instead of that, we've sort of exploded into a whole series of activities that I think may make sense on the short term, but in the long term may be flawed.
Yes, it's it's a lot of controversy there, I would say. Oh my gosh. From a historical perspective, this is a great question that came in. Are pandemics or near pandemics becoming more common? That is, examples of SARS, MERS, H1N1, or is the incident stable and we're just hearing about it more?
No, I think there's more of them, frankly. And what's changed things are airplanes. Is that, you know, at one time, plagues were regional. Some became global pandemics, but not that many. Now, with air travel and the globalization of everything that we do, I think that's that model has really completely changed the epidemiology of many of these diseases.
Thanks. Another question. Thank you for your informative presentation. Please share your thoughts on the value and sustainability of, I think we might have touched on this, the contact tracing for COVID-19 cases. Would you recommend this continue for several years?
I don't think it would be necessary for several years. The contact tracing, once you do it and you put the manpower, person power in terms of actually being able to trace these, it's incredibly powerful. And literally, you control disease. And so if you've got one activity that's moving in this particular direction, and then a new vaccine moving in another period of direction, and you put those two things together, then that means you're not going to have any disease.
A couple of more questions I'm going to put together. One, are you a proponent of those who are asymptomatic getting tested for either or both the disease and the antibodies? And if you are, when do you think wide-scale testing would be available so that everyone could be tested?
Widescreen availability of testing, both serologic testing as well as presence of the organism testing, that should have happened long ago. And one of the most limiting problems that we have in terms of dealing with this is we don't have that particular piece of information. So the answer to the question is, if you're completely asymptomatic, I don't know. I want to see you tested. I want to see you tested because I want to know whether you've already had the disease and you didn't know you had the disease. But once these contact tracing loops get developed and get organized, you can actually pinpoint and you can actually control in a completely local way these sort of R-naughts before they get started. And these little flames become extinguished, frankly. But it's expensive. It's not easy. But, you know, whoever said it should be easy?
Related to that, what do you think of the some studies that think that a much larger percentage of the population have either had the virus asymptomatically and have developed antibodies, or just simply have the antibodies for whatever reason? I mean, there's some people who estimate that it could be upwards of 60%, 70%. I don't know. What's your thoughts about that?
I think that for the number of reported cases that we have in the United States, which is a little over 1 million now, or 1.2 million, I think that you multiply that by 10,
Wow.
which would be the individuals who have had the disease. That's still only 10 million. We have a population of 330 million.
Mm.
This is just getting started.
Yeah. Okay.
And so I believe that this is more like 10 to 1. Now, if it's 20 to 1, okay, it's same ballpark. Is it 100 to 1? I don't think so.
Mm-hmm. Okay. Wouldn't a strategy, so another question comes in, wouldn't a strategy like that which Sweden is employing to get to herd immunity more quickly than a 9-year or more vaccine strategy, would that be a better strategy than waiting 9 years for a vaccine?
No, that's a great question, because the Swedes had basically looked at this and they said, we want this organism to actually percolate through the population as soon as possible, so that it gets above 55% or 60%, at which point herd immunity will sort of kick in and we're finished with it.
Mm-hmm.
Now, I can't see us doing that in the United States. Sweden is a very wealthy country and has an infrastructure. There are no poor people in Sweden. There are no poor people in Norway or in Denmark. The social network, or the safety net for individuals is so well developed that these are probably the only places where you could try to do that.
Yeah.
But I'm glad they are
Yeah.
sort of trying it, and it remains to be seen. As you know, the number of cases now, not only in Stockholm but outside of Stockholm, they're starting to take off now. And we still haven't seen the full impact of what's going to happen to hospital and hospital ICU units in Sweden. That's something worth following, certainly.
I know we're drawing near the end of our time, but maybe a couple of more questions before we end. One, in your experience, which you have a lot of this, how does politics and/or pharmaceutical company competition affect the development of a vaccine for antiviral medicine?
Yeah, it's a good question. The politics, frankly, run everything. And, because if the public sector is going to get involved in terms of developing products for pandemics, that's going to require public money. And so the minute it's public money, that equals politics. In terms of pharmaceutical companies, pharmaceutical companies are pretty lucrative operations. And so to the extent that they're going to respond to develop products that they could sell, then, that's just simply a business opportunity that they will pursue.
Okay. Here's a pretty technical question. I'll see if I can even read it to you. I've been tracking some work showing that nicotine binds to cholinergic receptors in the alveoli. Yep. Recent studies are now doing double-blind placebo control study with nicotine patch. I doubt that will work. Perhaps prescribe nicotine inhalation, not e-cigs. What are your thoughts?
You know, I know the cholinergic receptors story a bit, but I don't know that field well enough, and I frankly have not followed the science in those fields, so I don't feel as though I could correctly answer that particular question. So I'm going to say I don't know.
Mm-hmm. Okay. And one last question. I am set to do an NP swab testing for a local company testing their employees. I was thinking it would be more beneficial for blood testing at this point, only because swab would show if the active virus is present, but not if the antibodies are present. So your thoughts about that?
Yeah, I'd do both, but I certainly would start by doing the nasal swabs, because the nasal swabs are going to identify within that particular group who's got it, and then that group that you identify as positive, these are the individuals who need to be quarantined, because basically they are the highest risk factor to your particular group. I mean, it's like the story in the meat packers in Iowa. You know, once that gets started, and particularly in an environment where individuals are working pretty close to each other, boy, that's absolutely ideal for that particular virus. So I'd do both, frankly.
Okay. Well, we're just getting a lot of thanks, and I just want to say thank you, Dr. Laforce, for spending some time with the St. Anselm community, helping us to understand this virus, which is so unprecedented, at least in our lifetime. And you really appreciate your forthright answers and your honesty and your expertise. So maybe you can join us again in the future. I'd love to have you. And to all of our St. Anselm community who have tuned in, be on the lookout for other virtual presentations. And we're so happy that you were able to join us. So thanks again, and we will see you soon. Good afternoon.
Okay. Thank you, Dr. Fafaza.